Thanks for joining us today. I'm Jen Harris from Montgomery County, and of course, joining us is Dr. Bissell. She's here to provide an update, and following her update, we'll be able to answer any questions you may have. Obviously, if you have any questions, we're going to stick with the format. You can ask those questions using the chat or the Q&A. So thanks again for being here today.
Hi, Jen. Thank you so much. Good afternoon, everyone. Thank you for joining us. As expected, COVID cases have been increasing after the Thanksgiving holiday, people spending more time indoors, gathering, and colder weather, kind of a recipe for transmission of respiratory illnesses. It's happening here across the state and across the country, certainly more with the cold weather states as people tend to be spending more time indoors. This morning here in the New River Health District, our hospital systems reported 36 COVID positive patients and 1 PUI or person under investigation. Those numbers have gone up since last week. And don't forget, those are in addition to other illnesses and seasonal respiratory illnesses as well, but other issues and medical conditions that people had kind of prolonged or put off seeking care for. Almost 2 years in, I think we all need to accept COVID's here, it's everywhere. Our reported case numbers are not nearly accounting for all of the cases. For each reported case, there are probably 3 to 4 or more additional cases, and we have good data to give us those kinds of numbers. And at the same time, we have vaccines, and we have people who've gained immunity from infection. So we're at the point where, case numbers, they don't tell the story. They're not quite as relevant as trends in hospitalizations and deaths. The pandemic is moving in the direction of the next phase, which is endemic, meaning that it's here and it may be seasonal. Respiratory illnesses can be seasonal because when people are driven indoors, obviously there's more transmission, but it's definitely not going away. But we do have preventive measures, and we also are working on therapeutic measures as well, treatments. And those have gotten much better over the course of the pandemic as well. So if we look at our epi curves, we look at things weekly because we don't want to look at daily fluctuations. So that gives our epidemiologists a much better perspective of what's really happening. So if you look at the district as a whole, again, that the 5th of December will fill in some, but it certainly is good news that it's not already above last week. And so we don't expect that we're going to see this huge surge, but definitely our cases have increased from, when they came down after the Delta surge. And then if we go and we'll look at each community, Montgomery County, again, kind of the same thing. We did kind of see that increase post-Thanksgiving, and we expect this week to be about the same, might be a little bit more, but certainly not a huge surge. And then pretty much the same with each locality. So from Montgomery, we go to Radford. They did have an increase, but again, I would say look at the y-axis. We're not looking at hundreds of cases here. We're looking in the tens. So we're talking 40s, 50s, 60s for the week in Radford. And the same thing as we look at our other localities as well. Floyd, same thing. We're looking in the tens, not in the hundreds there. So we do expect to be about the same. And with Giles, again, very similar, kind of almost a plateau there where they're fluctuating a little bit in between that 20 and 40. And then wrapping up with Pulaski, same thing. We did come down, kind of have gone back up again, expected to be right around that same area in maybe the 80, 70, 80, 90 case range per week. And then we have our school-age children. Again, they came down after the Delta surge, just like we know most transmission occurs in the home. So as our community cases came down, our school-age children came down, and then after Thanksgiving, we started to see an increase. So following the exact same pattern. And then we have it broken down the same thing. Our college children, our college students, and our children are not a significant portion. It's mainly our community cases, but the trends in those two populations, the school-age children, we know the transmissions at home, so the school-age children follow the same trend as the communities. Our college students, pretty highly vaccinated, and a lot have already had COVID, so good level of immunity and not contributing significantly to our caseloads. And I think that's all we have for our epi curves. All the communities in New River Health District are considered to be at high community transmission as defined by the CDC. We expect to remain that way for a while as we go through our holidays and with Omicron variant. Please remember that Department of Labor and Industry requires that employers mandate indoor masking in areas of substantial or high transmission, regardless of distancing and vaccination status. We really should be practicing the indoor masking. You know, we do expect, I think the press release went out last week that the first case of Omicron was detected in Northwest in Virginia. I think I've most recently seen that it's in 30 some plus states. You know, we may see a sharp rise when Omicron really takes hold. Right now, we still have predominantly Delta, but in South Africa, it obviously became the predominant strain. In the United Kingdom, cases are doubling every few days, so they do expect that it will displace Delta and become the predominant strain as well. The good news so far is that there are no recorded deaths from Omicron in South Africa, Europe, or the United Kingdom. And this, again, follows the typical pattern where viruses will become more transmissible, but less deadly as they mutate. So Omicron does appear much more contagious than even Delta, which was more contagious than Alpha and the original COVID variant. So kind of following that same pattern. And we have to look at the denominator. So with it being more transmissible, we do expect that we'll see more people getting infected. So we still may see more hospitalizations and deaths. As more people get infected, even if it's a very small percentage of people who do end up super sick and needing to be hospitalized or end up dying, a small percentage of a very big number is larger numbers than what we have been seeing. So that's the case with any infectious disease. We are seeing people who are vaccinated and even those who've been boosted get sick from Omicron. But again, the vaccines are still doing their job in protecting against serious illness, hospitalization, and death. They're still working very well where they're supposed to work. And the latest CDC numbers, unvaccinated individuals are 6 times more likely to test positive, 9 times more likely to be hospitalized, and 14 times more likely to die from COVID-related complications. You know, COVID is changing. The landscape is changing by the day, by the week, and Omicron's no different, right? The virus is mutated. This one has a lot more mutations in that spike protein, which makes it more transmissible. But you know, again, we are kind of reaching that point where we are transitioning. It's becoming endemic, meaning it's not going to go away, and viruses will mutate. That's kind of their survival means. But we know what works from a prevention standpoint, and we know that we have a safe and effective vaccine. So, you know, again, we have a vaccine. We know what works for prevention. And back to the same thing, that people need to do their own individual and family risk assessments to inform their behavior. But we are making headway. We have those things now, and we have much better therapeutics now than we did this time last year when we saw a much bigger surge. The health department continues to focus on vaccinating, and our community partners continue to focus on vaccinating. Obviously, anyone who's not received any vaccines, we really want to get those first doses, second doses. We're doing third doses for those who are immunocompromised, and we're doing boosters as well. So we are trying to make the vaccine readily available and accessible to everyone, anyone who needs it. Late last week, the FDA did authorize booster shots for those who are 16 and 17. So right now, the way it stands, third doses are for anyone who's immunocompromised, and those are at least 28 days after the second shot of Moderna or Pfizer. Booster shots for Moderna and Johnson & Johnson are for those 18 and above. Those are the only ones who should have been getting the vaccine in the first place. For Pfizer, it's for those 16 and above. For Johnson & Johnson, the booster doses are at least 2 months after the initial Johnson & Johnson shot. And then for Moderna and Pfizer, the booster doses are at least 6 months after the second shot. So employers, we've been working, our business continuity team, Ashley Briggs has been working with our employers to schedule booster clinics, first dose, second dose clinics. Again, we're just trying to get the vaccine out there. Anyone who would like to work on scheduling something like that, please contact Ashley Briggs, A. Briggs, B-R-I-G-G-S, at nrvrc.org, New River Valley Regional Commission. We also still do have flu shots. We have not seen an explosion of flu, which is good, but we are definitely still seeing flu, and it's not too late to get flu shots. So please go ahead and get that flu shot if you haven't gotten it as well. One group I'd specifically like to address as far as vaccines are those women who are pregnant. CDC data shows that only about 30% of pregnant women have been vaccinated. Would like to highly encourage those who are pregnant, those who are trying to be pregnant, friends, family of those who are pregnant or trying to be pregnant, to go ahead and consider getting vaccinated. Those who are pregnant with COVID are at increased risk of adverse pregnancy outcomes, including preterm birth, stillbirth, admission to the ICU and on the ventilator, and having an infant, a newborn, who's infected with COVID. And pregnant women who get COVID are much, much higher risk of becoming symptomatic and being admitted to the hospital or to intensive care, and they have a 70% increased risk of death compared to those who are pregnant those who are pregnant and don't get COVID. So, I think we have to accept that COVID is still here, that COVID's not going away. We have the means to prevent it. We have to do our risk assessment. We are recommending that anyone who has symptoms needs to get tested for both COVID and to get tested for flu, because the symptoms definitely overlap and both are circulating. Again, we recommend the layered prevention, from vaccination to masking to distancing to being outside, respiratory etiquette, hand hygiene, and again, just doing those risk assessments. If anyone gets COVID, we are asking that people do stay home from work or school. And we really should be doing that with any communicable disease that we're symptomatic for, because when we have symptoms, we're at much higher risk of spreading it. So for COVID, we ask that those who are positive isolate for 10 days from the onset of symptoms or the positive test. And as long as symptoms are improving and they are fever-free for at least 24 hours without fever-reducing medications. Those who test positive and who are high risk of poor outcomes, there are treatments. There are the monoclonal antibodies, and then the new treatment pill from Merck was recently authorized as well. So those who do have COVID should contact a primary care physician about what might be the best options for them. And if you don't have a primary care physician, the community health center or the health department. So, again, regardless of what COVID variant, or what respiratory flu variant, we do have the tools to protect ourselves and protect our loved ones. The vaccines are safe and effective. They're free. They're readily available. You can pretty much go into any pharmacy. You can come to the health department. Our pediatricians' practices, some of our healthcare practices are vaccinating. In poorly ventilated indoor closed spaces, we recommend that people mask. If you are meeting indoors, we recommend increasing the ventilation as much as possible, opening doors, opening windows. If you can gather outdoors, that's always going to be safer. Bundle up if it's a little bit colder. Good respiratory hygiene, good hand hygiene. Those are all things that can help not only with COVID, but with other communicable diseases, both respiratory and those that are not respiratory, like hepatitis A, which affected our communities not too long ago. Lastly, don't forget we are seeing an increase in pertussis cases, also known as whooping cough. So anybody can be affected by pertussis. So we do recommend that those who it's been longer than 10 years since their last Tdap, which is the tetanus, diphtheria, and acellular pertussis vaccine. If it's been longer than 10 years or you don't know when the last time you got it was, that you look into getting a booster. And pregnant women get a Tdap booster with each pregnancy. So I think that's all I have. And we'll go ahead and look at questions.
Thank you for that. Our first question is coming in from Tom. Virginia has just gone over 1 million COVID cases. Shouldn't we eventually be reaching herd immunity?
So, herd immunity is not an absolute threshold. Herd immunity is, and it's influenced by a lot of things, not just people who've been vaccinated or people who've been infected. It's also influenced by people's behavior. But that is the concept that, we reach a level where the amount of circulating virus is decreased enough that it protects those who can't be vaccinated and those who are at very high risk of being infected. And we really don't know what that threshold is right now with COVID. We don't know enough about how durable and long lasting the immunity is. So for instance, when we talk about measles, we talk about other things that we followed for years and years and years, we do have a good idea of a threshold because we know that that's very durable, long-lasting immunity. With COVID and the mutations and the different variants, that's somewhat more of a moving target. We do know that people can get infections, reinfected. And we also know that there are breakthrough infections from the vaccine. Remember, the vaccines, they're doing their job. They're preventing severe disease, hospitalization, and death for the most part. But they're not really preventing that transmission. Again, I think we set our expectations a little bit high. But we do expect that as more people have been infected, as more people get vaccinated, even if there are reinfections, even if there are breakthrough infections, that those overall are going to trend on the milder side and not be the severe breakthroughs that lead to long-lasting complications that lead to hospitalization and death. And so, at that point, then, hopefully we will kind of see that it's going to ebb and flow. So I don't think herd immunity, I don't think that's really an achievable thing because we don't know enough about how long-term immunity lasts. We don't know enough about with these new variants that are coming up. So I think we have ways to go before we can say that, but we do expect that, even with reinfections, even with breakthrough infections from vaccination, that there is some protection there. Immunologic memory is pretty robust and that it does provide some protection.
Okay, thank you for that. Jean is asking, that 1 million figure, is that sobering for you, or did you ever think we would get to that number, or even 15,000 who've died to date?
Anytime you see about the number of cases and certainly the number of deaths, I think it is very sobering, especially when this first started and we didn't have therapeutics, we didn't have a vaccine. That's really, really the hard part. I think it's a little bit more challenging now because we do have the vaccine, and I think we all sort of expected that it was going to wind down a little bit more than it has. The Delta surge and certainly now with Omicron, it's taken the wind out of people's sails as we're trying to kind of get through this. But again, those case numbers are grossly underestimated. We know a lot more people have been infected than the cases that we've actually documented. And I think that's the reason that a lot of epidemiologists are now saying, we really need to shift our thinking more towards the outcomes than the actual case numbers. Number one, the case numbers that we have are probably not really a reliable number of cases. It's everywhere. It's spreading pretty rapidly, pretty readily. We really do need to focus more on the severe outcomes from it and doing our best to prevent. It's definitely frustrating. We're coming up on 2 years, and people are tired of it. It doesn't get tired. It's not going away. So we still need to encourage people to do everything they can to try and keep themselves and their families safe. And we still continue to encourage people to get vaccinated, because no matter where people stand, the data is pretty clear that the people that are overwhelmingly ending up with the serious complications, including death, are those who are not vaccinated now. So I think that's huge progress.
Okay, Nick is also asking, is it safe to assume that some of these new cases are reinfection? Is there any way to track that? And if there is a way to track that, are you already doing that?
If they're reinfection. So, there is a way to track it. It's not super simple though. And again, when you're talking the magnitude of cases, there's only so much you can do. There's only so much public health can do. But generally, if you're looking at calling something a reinfection, you want to have someone who the symptoms have totally resolved. They've had a negative test in between. They've had another, pretty high risk exposure, and then they have another positive test. And the kind of the cherry on top of that would be to do the sequencing to confirm that it's a totally different variant than the original one, because we do know that there are cases where the PCR test has stayed positive for longer than even the 90 days. And we do know that there are other things that cause this same constellation of symptoms. So it's really hard to confirm 100% that something is a true reinfection versus a persistent positive. There's a lot of things that we look at and a lot of things on our wish list. But again, as we get to the point, we know COVID is everywhere. We know that reinfection is a possibility, but we do know having had infection does provide some immunity to more severe consequences. And same thing with vaccination. We have breakthrough cases. We know we have breakthrough cases, but even though people may get COVID, by and large, the vaccines are still protective against the severe side effects. And so kind of like we do with flu, we do surveillance. We don't count every case of flu anymore, and there's estimated to be 40 million plus of those a year. But we look more at the severe consequences from flu, that people that end up hospitalized and dying, and our deaths in our younger populations as well. Because that's what really matters, is the impact from it and the outcomes from it, not so much the case counts per se, when you talk about something like this that is so readily transmissible and is pretty much everywhere.
Okay, Jenny is asking, Omicron has not yet been detected in the New River Health District. Is that correct?
So they're only publishing it by region at this point. And the first documented case, I think you saw the press release, was in Northwest. That being said, I think it is everywhere. The labs are sequencing so many samples, and they're looking at high risk, and they're looking for that S gene deletion as a higher risk that it might be Omicron. But I think the most important thing right now is it's probably everywhere. It is COVID, so the same prevention and protection measures work. The vaccine efficacy overall may be a little bit down, but it still does what it's supposed to do, and that's prevent the severe outcomes. So it doesn't really change a whole lot. Again, as I said, what we want to keep people out of the hospital. We want to keep people from suffering the long-term effects of it. So if it does supplant Delta and become the most common variant, then hopefully we would see overall milder cases. That being said, again, the more cases you see, you will see more people in the hospital. You will see more people who die. But again, we know that overwhelmingly, those are in folks who are unvaccinated. Overwhelmingly, those are in folks who have other comorbid medical conditions. So, I think the assumption has to be that it is all over. Although we are only reporting the Northwest case at this point, and they do report by region right now.
Okay, Eric writes, he had to jump on this a little bit late, so he was hoping that you would talk about the hospital capacity. How hard is it to get a hospital bed right now? And how short is the New River Health District on nurses right now?
So the New River Health District or our hospitals on nurses? I don't know what our hospital systems are doing with nurses. I mean, I think in general across the nation, hospital systems are struggling with nurses. That they're in need. I will say that our hospital systems are on normal operations right now, but they are extremely busy. And again, they've had an increase in COVID cases, but they have other cases as well. So it's not necessarily that it's all COVID, but COVID certainly adds to everything else they're seeing. So they still are extremely busy in the emergency departments. It's not unusual that they will be holding numerous patients in the emergency department waiting for a bed to open up, but they're able to manage right now. You know, I don't know specifically what their nursing situations are, i.e. if they have physical beds but not enough nurses. That would be a question for the hospital systems. As far as the health district, we do have some nurses who have chosen to leave because of the stress of the pandemic, because of a lot of other things, family things, early retirements, whatnot. So we are recruiting for some positions in public health. Unfortunately, the past 2 years has not been the easiest time for public health, so it's made, you know, recruiting a little bit more difficult. But we do have a great nursing staff here, and we have gotten some new nurses here who've just been a breath of fresh air, and who continue through thick and thin, through good and bad, to meet the needs of our community, and usually do it in a pretty happy way with a smile. They're vaccinating, they're testing, they're continuing to do the other public health things. We still see our clinics, and we're doing our family planning and our sexually transmitted infection clinics. We're still doing our baby cares, and we had to pivot and make adjustments, but they've handled it very graciously. They've handled it like the public health professionals that they are.
Okay, I believe that might be the last question we've had to come through. Let's give everyone a second or two to see if they have any other questions for you today. We appreciate you taking the time to be here to address all the questions. I don't see any more coming in, so I think we can call it a day today, and we look forward to the next time. Thank you for being here.
Thank you, Jen. Thank you so much.